So firstly, you're going to welcome Khan, who's coming to present his master's thesis. Khan did such a great thesis that he finished up with health psychology. After that, decided he didn't need to do anything more because he peaked and that was it. So he's going to present his research to you now.
Okay, so good afternoon, everyone. It's nice to see you all, considering we've all been in lockdown for the past, what, 3 weeks?
Is it screen sharing?
Is it screen sharing?
Just make sure. Sorry, I'm just not sure it's actually showing the in Zoom yet. Yeah. Just bear with us with some technical issues. Where is our Zoom screen? Yeah, should be sharing now. Yeah.
Cool. Sorry. So my master's thesis was on thought suppression and symptom reporting, and specifically it was around this phenomenon called the white bear effect, and I'll go into that in a bit more detail. Now, of course, seems a bit redundant to be talking about white bears. However, the white bear was a big phenomenon in thought suppression, and so it kind of led me using the name a little bit in my thesis. Oops. Okay, so today I'm just going to go through some background around my thesis, around symptom reporting and attentional factors, a bit around thought suppression and the white bear effect, and then go into some details around my current study, or study I did last year, the method, some results, and the discussion. So first of all, symptom reporting. You all would have learned a lot about symptom reporting throughout health psychology. It's a big thing. So we know that symptom reporting is highly prevalent in the general population, and it's high in certain physical illness groups. So my study just looked at some examples: chronic pain, asthma, COPD. So a lot of illness groups report physical symptoms. And also across psychological syndromes too. So this is not just unique to physical illnesses, but also along psychological syndromes, things like fibromyalgia, IBS, which is irritable bowel syndrome. These are things called somatic syndromes, which do have a psychological component to it. There's physical symptoms, but also a psychological component, and medically unexplained symptoms. So all of these syndromes, illnesses, it clearly shows that symptom reporting is high in the population. So this is a model from Koch et al. 2003 that I've used, and this is the symptom perception model. And so what you can see on the left is that somatic information, you get things such as physiology, from disease, from your emotions, from your environment. So that's your input. And specifically, it's selective attention. It's our attention that basically helps us or allows us to perceive different somatic sensations. So my focus specifically was around what kind of attentional factors actually promote thinking about or attending to somatic sensations. And this will become clear when I talk about thought suppression. So cognitive attention here influences the experience of somatic sensations. And the Pennebaker's competition of cues hypothesis shows this very well, in that we attend more to symptoms if if we have more external cues, then we're less likely to attend to information. But if the internal cues are more clear or intense, then we're more likely to attend to those. We also know that negative affect mediates symptom reporting through selective attention. So negative affect, so individuals who are high in anxiety, for example, will attend more to their symptoms because they are focused on their symptoms. Their anxiety gives them more of an individual focus to their symptoms, and so they will thus report more somatic sensations. Which leads me on to strategies. What kind of strategies do people use to cope with or when they are looking at their symptoms? Two main attentional strategies: distraction and sensory monitoring, that have been discussed in the literature. Distraction's quite a big one, so there's a lot of different types of distraction techniques. In chronic pain patients, there was no decrease in intensity when chronic pain patients distracted themselves from their symptoms, but there was also increased pain experience when they distracted themselves. So it does depend on the group and the sample studied. In healthy volunteers, distraction had better efficacy. It reduced the intensity of pain and it lowered the perceived unpleasantness of breathlessness. Sensory monitoring, on the other hand, was associated with high levels of pain and discomfort. So if you focus more on your symptoms, it seems more likely that you will express or feel high levels of discomfort and pain. So distraction and sensory monitoring are both two attentional strategies that people use in relation to symptoms. So my research specifically focused on thought suppression. So for the next 10 seconds, don't think of a white bear. Now, of course, you may know this is popular, I believe it's called the white bear effect in popular culture. When you say don't think of a white bear, what do you think of? A white bear. And of course, it doesn't help because there's a white bear in the background as well. So in thought suppression has not been widely studied in, it's been studied quite a bit in, I guess, in clinical psychology, but not so much within health psychology. The idea behind thought suppression, although the main idea that I was looking at was that thought suppression has been demonstrated to have what's called a paradoxical rebound effect. So what do I mean by that? Dan Wigner, a social psychologist, did a famous study called the white bear study, which is where it all comes from. And he famously asked people in his study to not think of a white bear. And participants who were asked to suppress or not think of a white bear, in fact, had increased thoughts of a white bear when they were subsequently asked to think about a white bear. So the act of suppressing actually leads to more thoughts of the target of suppression, which is why it's called ironic process theory or a rebound effect. Now, in the health psychology or in the literature, we found that suppression of painful, there's been some studies that have shown that thought suppression, there's a rebound effect, thought suppression rebound effect. So suppression of painful stimuli has been shown to produce longer pain recovery and higher subjective ratings of unpleasantness. But this is quite limited to cold pressor tasks, so plunging your hand in cold water, and predominantly studied within chronic pain samples. Not a lot of study has been done across different types of symptoms. Not a lot of study has been done across healthy populations. So those two aspects, this is where my study comes in to hopefully fill some of the gap within the literature. My study then, the aim of my study was, does suppressing thoughts about physical breathing sensations lead to more thoughts about physical sensations or the reporting of worse physical symptoms? So again, with this rebound effect, if you suppress a thought, then the rebound effect was that you're more likely to have those thoughts, or you're more likely to report worse physical symptoms in the case of health psychology and symptoms. So the picture on the right is actually the breathing apparatus that we used. I did this study with a colleague from Germany who was a clinical psychologist working with psychosomatic disorders. So her focus in our study was around health anxiety and around psychosomatic aspects, and my study was more focused around the attentional thought suppression aspects. So we recruited 151 healthy volunteers from the university mailing lists, and participants, the main thing was participants were assigned to either three conditions. They were assigned to a focus condition, a distraction condition, and a suppression group. And that's a bit of a typo there, sorry. So focus, they were told to concentrate on their body sensations. Distraction, we're told to think about their lounge at home. And as you can imagine, the suppression group was told to not think about your sensations. And the task that they were asked to do with regard to these sensations was that they were asked to breathe through a respiratory device against different levels of breathing resistance. So that was the device on the right there that controlled the breathing or the resistances, and there was a tube where they would breathe into. Definitely lucky that I didn't do this throughout COVID time, otherwise no one would have wanted to do my study. So I count myself lucky in that regard. And there were two parts of the study that I will go into. So there were two phases to this study. First phase, participants were asked to focus, distract, or suppress any sensations depending on the condition that they were randomly assigned to. And we had a number of sets of 5 breaths. So 5 breaths in, so 1, 2, 3, 4, 5, that was considered a set. And there were a number of sets. I believe in the first phase there was about 12 sets of breathing. After each set of breathing against a resistance, participants rated how much they focused on their body sensations. At the end, participants filled out a symptom checklist of the bodily symptoms related to breathing to see how many symptoms they felt. In the second phase, participants were told that they could pay attention to anything they wanted to. So they didn't have to follow the instructions from the previous phase. And again, at the end of each set of 5 breaths, participants rated again their focus on body sensations, but we also asked them to rate the unpleasantness and the intensity of their resistance. The symptom checklist was filled in again. So, my results. Just to reiterate, the rebound effect hypothesis. So we were hypothesizing in accordance with the rebound effect in the research on thought suppression, that the suppression group will experience this rebound effect in which their thoughts about their bodies and symptoms will increase in phase 2 compared to phase 1. Phase 1, not going to think about my symptoms, don't think about my symptoms. Phase 2 will increase a focus in those symptoms, or they will. I used 3 times 2 ANOVAs to test the between group differences. There are quite a lot of analyses I did run, but for the purposes of time, I'm just going to keep it to this core hypothesis here. So here you can see the graph depicting the mean body focus and mean symptoms. Mean body focus is on the left, mean symptoms is on the right, and the different groups. So of interest are the suppression groups, and as you can see, the mean body focus was lower in phase 2, which is the black bar. Now, for body focus, it seems that participants overall did not have more body focus on their body or more focus on their sensations than in phase 2, which meant that a rebound effect was not shown for body focus. In the mean symptoms, however, they did show an increase in focus on symptoms, on reporting of symptoms. However, this was not significant compared to the other groups. I believe here that this is supposed to show dyspnea. I think it's a typo, it should be mean dyspnea. So instead of overall symptoms, we also looked at specific dyspnea symptoms, dyspnea meaning breathlessness or breathless symptoms, because that's the task that they were doing. And they did show a increase, but this was not significant again overall across the groups. So this is a summary of the results. The suppression group had significantly lower body focus than both the distraction and the focus group. There was an increase of symptoms across phases, but no significant difference between the groups. And there was also an increase in dyspnea symptoms, but no significant difference between the groups. With regards to intensity and unpleasantness, there were no significant differences between the groups. So, was there a rebound effect? The suppression group, if the rebound effect did exist, then you would expect the suppression group to have higher levels of body focus and higher levels of symptoms. Unfortunately, the suppression group had the lowest level of body focus averaged across the 2 phases, which meant that a rebound effect was not supported. And although general symptoms and dyspnea did increase across the 2 phases, it occurred in all groups, which meant that the suppression group was not unique compared to a focus group or a distraction group. So, our hypothesis of a thought suppression rebound effect. So, why was there no rebound effect? The majority of thought suppression literature, especially within a health context, has been extremely mixed. So there are a lot of different working variables in relation to the study of thought suppression. Some potential reasons why there was no rebound effect. I did a qualitative analysis of some of the thoughts and the strategies that participants in the study used. We asked them, what exactly did you think about during the task? And many participants in the suppression condition actually said that they used a form of distraction instead of suppression. So they actually weren't following the task. It was actually very hard to just not think about symptoms. They thought about something else, such as what they needed to do after the study, or they were thinking about the food they wanted to eat or something like that. A suppression of breathing is difficult. So compared to a white bear, breathing symptoms are integral to daily life. And so it actually might be that it's hard to suppress breathing symptoms compared to a novel thought like a white bear. Trying to suppress your own breathing sensations, considering they're so integral to, I guess, functioning, might actually be very, very hard. Another reason, participants got used to the breathing rhythm. When they got used to the resistances, their ratings were not as high as when they first experienced the breathing. So they may have gotten used to the resistance and they weren't rating as highly because they got into a pattern. And this was the case because we had a set amount of, or set level of resistances. The computer programmed a set level of resistances. So they could have just gotten used to it. And the length of the task too. It was quite a long task. They were in there for about 45 minutes. So a brief increase in symptoms may have occurred, but this may have dissipated as time progressed. Just a few limitations. They had to give an immediate rating under pressure. So immediately after they finished breathing, they were asked, how much do you focus on your body sensations? Giving a rating under pressure, they may not be accurate. Also, there's a bit of irony in here too, in that actually participants quickly switched from suppressing. So you imagine you're told, don't think about your body sensations. And then immediately after that, you have to then give a rating and think, oh, okay, did I think about my sensations? Which is paradoxical. And I didn't think about that until actually when I was writing my discussion, and I realized that's actually extremely ironic. Self-report bias, we used numerical rating scales, and there's always going to be some degree of self-report bias there. No real-time assessment was used. I think this was a big one. In Dan Wegner's study, this is the white bear study, the original one, he used a bell where participants, every time they thought of a white bear, they rang a bell, and it was like a real-time measurement or assessment of how many times they thought of the white bear. We didn't use a real-time assessment here, and in hindsight, it may have been better to use this to get a real-time picture instead of a numerical rating scale, which would have been subject to the different types of biases that come with self-report. However, on a strength, the study is very novel in that no other study, to my knowledge, has looked at thought suppression in relation to dyspnea symptoms. And our study also had a very healthy sample size, as well as was in a healthy population, which is not widely studied in the literature. So we found no evidence that a thought suppression rebound effect existed when applied to dyspnea symptoms within 149 healthy participants. This was because it was 151 before, 2 were excluded because they didn't follow the instructions at all. Research on thought suppression and physical symptoms generally is mixed and ranges and is limited in methodology. So like I said before, it's very limited to chronic pain patients, very limited to cold pressor tasks. So this study diversified the study parameters around thought suppression. And it's very interesting because in some cases you see a rebound effect in, with regard to symptom reporting, others you don't. So future research on thought suppression and physiological symptoms is needed. There's a lot of other different types of symptoms that may be interesting to think about and perhaps explore. One might be, for example, skin itch, having a itch in your skin and then trying not to think about that. Breathing, in fact, may just be a very hard task to do, and that may have interfered with not finding a rebound effect. Oh, thank you very much for listening.
Do we have any questions? We've got a few moments for a few questions. I was anticipating lots of questions back in today's slides rather than the Zoom. Okay, in that case, we're going to take Becky Kahn. It does really kind of, I think that clinicians aren't overly educated about this research and that many do use distraction as a strategy in suppression, and so it's a useful thing to think about and probably extend on. And I was curious about the difference between, say, panic attacks and asthma attacks, and whether you might get different responses if you used those two symptoms, which are respiratory related often, have respiratory symptoms related.
Yeah, there's a lot of, I guess it really just depends on how internally focused they are. People with anxiety disorders, for example,
Yeah.
So it really just depends on what strategy they're using and why.
Yeah, definitely. Be very interesting.
Get to present a view. I'm used to a Mac.
Okay. Bilingual. Let's go to sharing. So next up we have Kate, who's going to be presenting her PhD research. Kate is in her final year
Yes.
of her PhD and is presenting on her topic.
Is it possible to go into the view where you can see your notes at the bottom? No worries if not.
Oh, you might struggle with that with these screens
today.
today.
Oh, okay, that's no worries. All right. Cool. Yeah, so thanks everyone for coming along today and also for attending via Zoom. I'm just going to stick in this box so people on Zoom can hear me. So today I'm going to be talking about some of the results from a large experimental study that we conducted in the first year of my PhD, which was looking at the effect of multimodal emotional expression on social closeness with a digital human. And so for those of you who attended my seminar last year, you might remember this study, but so today we're actually just going to be presenting some different data from that same study. So you might notice a familiar face here. So artificial agents are increasingly being used in healthcare contexts and in health psychology, and they've shown to be effective for doing a range of different types of tasks, from things like healthcare monitoring, all the way through to intervention delivery and even providing a bit of companionship. And by artificial agent, what I mean is any kind of social interactive technology, ranging from things like social robots right the way through to chatbots. So digital humans are a type of artificial agent. More specifically, they're like a new type of embodied conversational agent. I'll try to avoid getting too jargony today, but basically what that means is like an interactive computer interface that has some form of physical embodiment. So whether that's just a face or a full body. And what makes digital humans unique is that they generally incorporate some aspect of artificial intelligence. So for these particular digital humans you can see on the screen, this is what we've been working with in our research with soul machines. And so they use real-time sensing and computer graphics and also have emotion classifiers as sort of these AI components of them. So digital humans may be a particularly good technology to deliver health psychology interventions. This is because they're easily scalable, so all you need to access one is a computer, a smartphone or a tablet and an internet connection. They're also available 24/7 to provide support, and they may be slightly more engaging than, say, a text-based website. But as they're a relatively new technology, more research is needed to understand how we can create good relationships with digital humans that are delivering these sorts of interventions in order to improve how engaging and effective they will be. So there's a lot of research that shows the importance of quality relationships in healthcare contexts, so both between physicians and patients, as well as more companionate type relationships with support people. So as you can see here on the slide, quality relationships between healthcare providers and patients can have direct and indirect effects on health outcomes. So by indirectly, I mean influencing outcomes such as treatment adherence and engagement, which then have flow-on effects to improving treatment outcomes, or more directly through reducing feelings of distress, which has implications for cardiovascular, neuroendocrine and immune system functioning and therefore outcomes. Close companionship can similarly affect health outcomes in a direct and indirect way. Directly is the same pathway basically, and indirectly it might be more providing things like social support. So ultimately, from this what we can see is that close relationships are a really important aspect of healthcare for patients. So a big body of research is showing that it is actually capable to form a relationship with a computer or other forms of artificial agents. So a couple of researchers at Stanford, Reeves and Nass, in the late 90s and early 2000s, conducted a whole ton of experimental studies demonstrating how when a computer delivers social cues to people, they tend to respond with similar social cues and social judgments and behaviours, much like they would as if they were interacting with a real person. And this effect goes as extreme to show that if you position people in a way with a computer so that they believe the computer is part of their in-group by a colour affiliation, they then go on to demonstrate in-group social perceptions and behaviours and are more influenced by the computer than if they're judged or made to believe that this computer is part of their out-group. So it seems like it is possible to form relationships with computer agents, and we can also see that there's a bunch of research with different kinds of artificial agents demonstrating the health benefits that people have with artificial agents. So, for example, with companion robots like Paro, which you might have seen in Liz's lab. This is the fluffy baby heart seal. So Paro has shown to reduce feelings of loneliness as well as improve physiological stress. So through that, we can see it's having a direct impact on health outcomes. And there's also other research with embodied agents kind of showing how they can influence health behaviours and improve health outcomes in this more indirect way. So I guess from this what we can gather is that artificial agent relationships can have benefits for health outcomes, but it raises this other important question in the research, which is really how do we design these relationships to improve their quality and therefore hopefully improve engagement and effectiveness of artificial agents delivering these interventions. So to try and understand this question a bit better, we conducted a systematic review of 43 papers across health and engineering literature. And from this, we were looking at a whole range of different relationship quality type outcomes. And from this, we could also see there's a whole range of different factors that contribute to relationship quality with embodied agents, and I'll go into some more of the specifics shortly. As we were sort of thinking about moving forward with this digital human literature, we decided that we wanted to explore the outcome of social closeness more specifically. The reason being that closeness encompasses like a relationship that's a bit more companionate in nature and involves behaviours like reciprocal self-disclosure and warmth and help and support, frequent interaction. And we felt like that kind of relationship quality tapped into some of the roles that we could envision a digital human performing, so being a companion for loneliness or being some kind of peer supporter or health coach. So we decided that we wanted to explore how we could improve social closeness as a specific relationship quality outcome. And unfortunately, in our review, there were only 5 studies that actually looked at how you improve closeness. A handful of these looked at a combination of different agent design features at once, so it's really hard to tease out which of those features were actually driving the improved relationship. Another one had an insignificant result, and the other one is just saying that if you acknowledge how much exercise someone did, that seemed to fare pretty well with them, which is not too surprising, but it also doesn't give us very much to go off. So from that paper, we proposed a new theoretical framework. This was informed by another theory in Liz's lab, which is the framework of robot-patient communication, which is informed by techniques identified in doctor-patient relationship communication and relationship building. But we also used some of the results from the included studies in our review to inform this, and we felt like this would be a framework that we could work with moving forward experimentally to try and tease out what are some of these factors that would improve closeness with embodied agents. And so just to describe how this works, basically what we're proposing is that factors related to the user, the agent, and the context may have interaction or main effects on user outcomes. And user outcomes could pertain to the relationship quality, or they could be about the person's health outcomes. So because we didn't have very much to go off in the literature that's already been done, we turned to factors that have shown to improve closeness in human relationships. And we've got a few different factors up here on the screen. So these are things like self-disclosure, relational expression, so that's when you're sort of stating to someone how important the friendship or relationship is, having empathic accuracy, And something we noticed across these techniques is that they all require the capacity to express emotions. And we also noticed that emotional expressiveness itself was a closeness building technique, especially in female relationships. So we thought that this could actually be a good closeness building technique to focus on with digital humans. The name of the technique that we focused on, we would call multimodal emotional expression. That's because digital humans can engage in this type of emotional expression. So basically what that means is you're delivering emotional cues that are congruent through more than one communication channel at once. So perhaps we're showing an angry face and we're also giving off an angry voice at the same time. In the literature, multimodal emotional expression has shown to improve social perceptions of embodied agents that are related to relationship quality. So things like perceived supportiveness and caring, perceived warmth, but nobody's actually looked at the effect of this technique on social closeness directly. So we wanted to explore that in our study. So the aim of our study was to investigate whether multimodal emotional expression and gender interact to influence social closeness with a digital human, and a range of secondary outcomes such as empathy perceptions, stress, loneliness, and people's desire to interact with the digital human again. The reason we were thinking there'd be a gender difference is just based off in that prior literature where emotional expressiveness was shown to be more important in close female relationships. So we expected to find that the effects of this technique might be stronger for females. So here's just a quick overview of some of the key parts of our method. So we recruited 198 adults aged 18 years or older with English fluency from the Greater Auckland area. We had a gender quota, so we needed about 100 males, 100 females, so that we had enough statistical power to run our gender analyses. When people came into the lab, so they came into the University of Auckland Clinical Research Centre for one 45-minute session. When they came in, they interacted with one of 6 versions of a digital human that could vary by its face type or its voice type. So in terms of the face, it might have no face, so a black screen, a neutral face or an emotional face, and I'll show some examples shortly, and it could also have a neutral or an emotional voice. And people were block randomized by gender to interact with one of these 6 versions. And the interaction that they had was a 15-minute structured conversation, which is called the relationship closeness induction task. So this is a task that has been reliably shown to induce a sense of closeness between human strangers in experimental psychology research. And it basically involves 28 questions that gradually increase in intimacy, ranging from things like, how old are you, through to, can you describe the last time you felt lonely, and what's your biggest fear? So people had this interaction in private with a digital human, and they both were taking turns at asking and answering these questions. In terms of our outcomes, so our primary outcome was closeness, which was measured through the ARCID follow-up measure. Then we also looked at empathy perceptions, which was using a psychometrically validated scale from a Reeves and Nass paper, which was called the Caring Perception Scale. We also looked at subjective and objective stress. So that was using an Empatica watch, which was collecting electrodermal activity, blood volume, pulse, and skin temperature. And then for stress, subjective stress, loneliness, and desire to interact again, these were measured using 100mm visual analog scales. So I'm now just going to talk a bit more about the digital human from the study and just provide a quick demo. So in terms of the video I'm going to play today, it's the same digital human, but the interface is slightly different to what people actually experienced in the study, which actually looked a bit more like the digital humans you see on the left. So if you were the no face condition, you're talking to a black screen. If you're a neutral face, you get sort of like a deadpan digital human the full way through. And if you're got an emotional digital human, she might be happy, she might be showing some concern, and her emotions kind of change during the interaction. So the digital human here it's delivering the same conversation that people had, but I'll just note that she's got an American accent, and you'll notice she's sort of got different clothes and a different background. That's because we can't actually access that old digital human because the technology is already advanced. So I had to sort of recreate the digital human for this. So so just take a minute. Hopefully everyone in Zoom can hear the video, but let me know if there's any issues.
wish I could play rugby. Maybe one day I'll get there. What about you?
Sorry, there seems to be a
What is
lag with the
something
sound
you've
in the
always
video.
wanted to do but probably will never be able to?
Paint a masterpiece.
Yay, that's a good one. The next question is, if you could travel anywhere in the world, where would you go and why?
I'd like to go to Iceland because I really like hiking and it's got really nice nature up there. What about you? Where would you go?
I would really love to go to Antarctica. I think it would be such a technical achievement to get me there, and also, not many humans go there, so I could take pictures and videos to bring back to show everyone.
Yeah, so you kind of get the gist of like the sort of questions and answers that the digital human was giving. And so in terms of the digital human, she's actually modeled off a real person who's mixed ethnicity, and she was also the vocal actor for us in the study. So she provided a real human, neutral and emotional voice. We conducted a manipulation check to ensure that our conditions were significantly different. So we did this sort of objectively and then subjectively. So we ran an emotion classifier across the two emotional and neutral voice clips and found that there was a significant difference. And so this was with a classifier that was operating at about 80% accuracy. So we feel like those results would be fairly reliable. And then there was also a manipulation check as part of our questionnaire where people rated the emotional face as more expressive than the others. However, the no face was rated as more expressive than the neutral face, which is interesting, but perhaps it's just that if there's a face giving you no cues that you're expecting, it might come across as less emotional than if it's just a black screen where you know it's not capable of giving you those cues. And an emotional voice was also perceived as more emotional. So, very quick overview of the procedure. So, people came to the lab, provided an informed consent, put the stress sensor on, completed the baseline questionnaire with demographic and psychological variables, block randomized by gender, completed the relationship closeness induction task in private for about 15 minutes. Then I return to the room, they take off the sensor, they fill in their follow-up questionnaire on their perceptions of the digital human and how they're feeling, and then they're provided with a $20 voucher for their time. So in terms of our data analysis, we first checked for violations of test assumptions and applied bootstrapping for data that was not normally distributed. And then we conducted a series of three-way factorial ANOVA to analyze the effect of face type, voice type, and gender on outcomes. And then we conducted post hoc tests with start correction. So we ended up analysing 195 participants due to some data processing errors. And our sample ended up being predominantly young adult single university students. We had about a 50-50 split of male and female, and our sample was a range of ethnicities. So we'll just get into the key results. So these are the key findings for relationship quality. So both social closeness and empathy perceptions. Here we see significant two-way interaction effects that are very similar between gender and voice type. So closeness with an emotional voice digital human was greater for females than it was for males. And then in terms of empathy perceptions, females perceived that digital humans with a emotional voice were more empathic than males. There was also a significant main effect of the emotional voice, where overall it was perceived as more empathic. These are the findings for subjective health outcomes, so perceived loneliness and perceived stress. And for this one, we also see similar two-way interaction effects between gender, however this time it's with face type. So in terms of loneliness with digital humans that have no face, females felt greater loneliness when they interacted with no face than males, whereas males felt more loneliness when they interacted with a neutral face compared to females. And then in terms of perceived stress, so for males, they felt the least amount of stress with no face, then an emotional face, and then a neutral face digital human. And females felt more stressed when they're interacting with no-face digital humans. So as you can see, there's some distinct gender differences in their preferences. In terms of physiological arousal, the only significant effects that we had were with average electrodermal activity over the interaction. And this was just a significant main effect where there was greater electrodermal activity or physiological arousal when people interacted with an emotional voice digital human compared to a neutral voice. It's not really clear what's driving this effect. I guess we had originally intended this to be a marker of objective stress, but I guess it's physiological arousal, so it could also be excitement, and it's hard to know what this is showing. Given the other results, possibly it means something different depending on if you're a male or a female. And then in terms of the desire to interact again, females would rather interact with an emotional voice digital human again compared to a neutral voice and compared to males, whereas males were more likely to want to interact with a neutral voice digital human compared to females. So from this, what we're really roughly getting is that females are preferring a face and they're preferring an emotional voice, whereas males are preferring like a black screen and a neutral voice. So our findings can contribute to our theory. They provide some supportive evidence showing that there's interaction effects between user characteristics and agent features on user outcomes. There's definitely some limitations with our study, which I'll kind of zoom through because I'm running short on time. We did have some issues with our language technology at points, specifically with utterance detection and some speech-to-text translation. I don't believe that this will be a long-term issue as the technology is changing rapidly, but even comparing from when I started my PhD to now. But in this experiment, it manifested as though sometimes the digital human seemed like it was interrupting people or asking them to repeat themselves when they're disclosing something quite sensitive. It's also not really clear what males truly prefer. Maybe they prefer a blank screen and a monotone voice, or maybe it's that they would have preferred to interact with another male or do some sort of other kind of interaction activity. In our study, Māori, Pacific people and gender non-binary people were underrepresented, so it's not clear what their preferences are for digital humans, and further research should look into this. We also need to test this out with patient populations because our study was with a predominantly healthy student sample. And we also need to test our theoretical framework a bit more. So what are some other agent features that improve closeness and health outcomes? And similarly, what are some other user features that, user characteristics that contribute? So in conclusion, multimodal emotional expression may improve closeness and health outcomes in female users. The same can't be said for males from the study. And our results of the study could inform the design of digital humans that might be delivering health interventions in future. Cool, thank you for listening. I also just like to thank my supervisors, Elizabeth Broadbent and Mark Sager, Soul Machines for the engineering support, our research assistants, Andy and Elise, our lab, and also our participants. Cool, thank you.
Any questions? Way to make presenters feel good about themselves. It's very hard to see if anybody has questions from Zoom. So if you do have questions, please feel free to pop them into the chat on the right-hand side. Can I have a show of hands who here would go and see a digital human or use a digital human for therapeutic purposes? Yay! Who here's unsure? Okay, interesting, isn't it?
Yeah, and because I personally feel like this technology wouldn't ever replace a human, but I think it might be a good stand-in for if your alternative is nothing, like, you know, maybe
Or a big weight.
Yeah, definitely. So it might just be some sort of stand-in type intervention, or yeah.
It's one of the pushbacks you hear a lot from clinicians is that I would never see my clients see some technology, it's never going to be as good as me, but actually blended care models for people who have access to technology as well as the clinician while waiting is shown to be really effective. Questions? All right, well, thank you, Khan and Kate, for your presentations today. Really appreciate it. I'm sure there's going to be lots of reflection and thinking on this, even if not shared out loud. I think perhaps we're a bit out of practice with talking in groups, maybe. So lovely to see you all again. We're face-to-face next week as well. And thank you to people that Zoomed in. As always, we'll upload this to YouTube for those that are interested or couldn't make it today. Thank you, everyone.